Sir, we are live. You can start.
Okay, fine. Thank you. So, a very good evening. On behalf of Indian Academy of Neurology and Epilepsy Subsection, I extend a warm welcome to all of you for this educative session focused on the management of refractory and super refractory status epilepticus. And it is our privilege that Professor Trinka, who is a chairperson and head of the neurology department at Medical University Salzburg, has kindly agreed to deliver this lecture. And I think the people who are working in the field of neurology, epilepsy, and especially in India, I don't think Dr. Trinka requires any particular introduction. In the last 2 decades, he has made a tremendous and one of the most prolific researcher and impact in the field of epilepsy and status epilepticus. As till now, Salzburg was known because as a place where the Mozart was born and the sound of music was filmed there. But now in the neurology faculty, at least, Salzburg is known by the Salzburg's criteria for the non-conjugal status epilepticus. And it is credit goes to, I think, Professor Tinka to put Salzburg on the map of epilepsy and neurology all across the world. So it is our real privilege that he will be discussing one of these topics of super refractory status epilepticus. I once again thank you, sir, for accepting our invitation and to be with us and all the Indian neurology fraternity. And with that brief introduction, I will hand over to you.
Well, thank you so much for your kindest introduction, and I'm very happy to give you some of the more recent developments, what we have in super refractory status epilepticus. And having said that, I also have to apologize for being very short in time because I have tickets for the Salzburg Opera Festival, so I have to leave on time. I'm sorry for that. But it's a great pleasure to be in India again, at least virtually. And these are my disclosures. I will go through the definition and epidemiology of superrefractory status. And by saying that, there is an unmet need of looking at superrefractoriness in other countries. There are very few epidemiological studies. Causes and consequences, which is important. Then coming to the pharmacological treatment of superrefractory and also non-pharmacological treatment of superrefractory. Well, first of all, what is refractory? Our terminology is related to the responsiveness to anti-seizure medicines. And if it doesn't respond to the first anti-seizure medicine, we call it benzodiazepine resistant because benzos are the first. If it fails to respond to an adequate dose for anti-seizure medicines, then we call it refractory. Benzos plus anti-seizure medicine equals refractory status. Superrefractory, we have again the response to anesthesia. So if 24 hours of anesthesia cannot control status epilepticus, we call it superrefractory. Then, of course, we have some other, this is prolonged refractory, then we can say prolonged superrefractory, which does not matter anymore. I think the categories benzo-resistant, refractory, and superrefractory are important to say, and this goes with time. So time matters also when we define status epilepticus, and we know that generalized tonic-clonic status or bilateral tonic-clonic status starts at 5 minutes of ongoing seizure activity or of seizure activity where the patient in between cannot recuperate without going back to baseline. And we have the group of non-convulsive status epilepticus, which is also important, that focal status with impairment of consciousness starts at 10 minutes. And absent status, we also defined it at 10 minutes, but prolonged absences are very rare, very rarely longer than 1 to 2 minutes. So we could move T1 in the absent status earlier. The important thing is that once status is ongoing, after half an hour, you have the high risk of brain damage, and the consciousness is increasingly impaired in tonic-clonic status epilepticus. So the patient is at the end in coma with ongoing ictal activity. And this comatose non-convulsive status epilepticus is the most threatening, the most dangerous, the one with the highest mortality. In focal status with impaired consciousness, the time limit T2 is around 1 hour. Then we see brain damage in MRI. And for absent status, we don't know. So these refractory status belong to this group. This is their phenomenological appearance. And to this group, which is focal, but it is moving on. And both, you see, refractory encompasses T2. So you're fighting against brain damage. What is interesting, we learned in the past years that the status epilepticus with prominent motor symptom, they cluster into different electroclinical phenotypes. So it's not only the semiology, focal motor evolving to non-convulsive, but it's also the EEG, for instance, LPD or GPT, the etiology, which is cryptogenic, and treatment refractoriness. This forms cluster 1. Cluster 2 is spontaneous burst suppression on EEG, superrefractoriness, progressive symptomatic etiology, and you have myoclonic convulsive evolving into non-convulsive. So you remember those ongoing comatose non-convulsive. These two clusters. The other two clusters are treatment responsive. That's the one without LPDs. That's the one without burst suppression. They have convulsive phase only. Previously, we thought the one with convulsive phase are the most dangerous. No, it's the one with the non-convulsive in the comatose. So type 1 and type 2, cluster 1, cluster 2 are the refractory, superrefractory. And if we look at the non-convulsive status epilepticus types, we can confirm this, because if we take the Glasgow Coma Score into equation, the one with the deepest impairment of consciousness, 3 to 8, they have a presence of spontaneous burst suppression, they are acute symptomatic, and they are drug resistant. So this is a retrospective series, but it shows you clearly that semiology, assessment of coma, the impairment of consciousness, etiology, EEG, and drug responsiveness, these are the 5 factors which cluster together. Well, how often is it? There are only 2 population-based studies, one in Salzburg and one in Finland. And there is a recent one coming out now from Norway, which shows the same incidence rate. So the incidence was 7.2 for refractory and 1.2 for superrefractory. And in the Finnish study, there was refractory 3.4 and for refractory and 0.7 for superrefractory. But if you look at the confidence interval, they are overlapping. So there's basically not much difference. This had a urban population. In Finland was a rural population. But nevertheless, the mortality in both studies was around 1/3 of patients. So this is a rare condition, but it's life-threatening. When we look what are the causes, in our population, cerebrovascular prevails. Around 45% have cerebrovascular. And if you look at how many patients had epilepsy before, this is only 1.4%, which occurred in defined electroclinical syndrome. So it's no longer a disorder or a problem of epilepsy patients. Once they are treated well, they're doing fine most of the cases, and the vast majority is symptomatic due to lesions, due to structural pathology or progressive pathology. So the overall incidence, not only refractory, is 38 per 100,000 per year. A specific problem is the one which go into refractory status and you don't find the cause. In a global audit, which we did several years ago, we asked the doctors, what are the causes you found? And there were infections, there were vascular, anoxic tumors, but look at the number of, out of 776 patients, 26% remained unexplained, cryptogenic. And this is what we call now NORSE, new onset refractory status epilepticus, without active epilepsy, without pre-existing relevant neurological disorder, and without clear explanation, which you can identify early on. So this NORSE is a category, a label to let you think about other causes than the usual ones. And in this systematic review, looking at 1,300 published patients, children and adults, about half of the cases, NORSE could be attributed to a different etiology. This was autoimmune encephalitis, non-paraneoplastic or paraneoplastic, and rare infections. But also other causes were described, for instance, genetic or congenital disorders, toxic, vascular, and degenerative condition. So it's a mixed bag of etiology. But still, this is the identified, explained NORSE cases. If you don't find the cause, half of them are still cryptogenic, whatever you do. And how tricky it can be, how unbelievable. I just tell you this, the story of one of our NORSE cases, which impressed the whole department. And unfortunately, this person did not survive. At the age of 14, this was 2011, he had his first episode of refractory status epilepticus. At 2011, there was no definition of NORSE. So then he was discharged with normal cognitive further development. He was 14 years old. He was seizure-free on levetiracetam and lacosamide. He started to have some attention deficits, but he finished school, got his driving license. He was withdrawn from anti-seizure medicine at 16. And then in 2018, and remember, we had this consensus definition there, he had seizure relapse with superrefractory status epilepticus. After that, he developed drug-resistant epilepsy. He was admitted for pre-surgical evaluation. Then we looked at the genotyping, etc. And so the problem is that he had a mitochondrial disorder, which was not clear. And in the below, you see the first episode of NORSE. So the clinical features were there: bilateral tonic-clonic, repetitive focal impaired awareness seizures, focal motor seizures, non-convulsive status. You see the treatment and the MRI changes, which are quite impressive. And then at the end, we looked at during the pre-surgical workup, we looked at the genetic, and this person had a fast KD2 mutation, which usually gives you a different type of epilepsy. But you see, NORSE is worthwhile in really looking for the cause. So having said that, the acute symptomatic is not one. We have to distinguish those with acute treatment failure events, for instance, low serum levels of anti-seizure medicines or inappropriate description of anti-seizure medicines, febrile illnesses, etc., in a patient with pre-existing epilepsy. Mostly good prognosis. Or you have an acute primary CNS pathology, including trauma, infection, cerebrovascular. Poor prognosis. Or you have an acute secondary CNS pathology, including metabolic disturbances, organ failure, acidosis, hepatopathy, systemic infection or fever, acute secondary CNS, and then you can have a fourth category, drug or alcohol intoxication or alcohol withdrawal. These etiologies have a different prognosis, and you see it here. In hospital mortality, on the lower graph, you see that the acute treatment failure events had a very low in-hospital mortality, but the acute primary and acute secondary, 30% in-hospital mortality, and they were drug resistant. This is category 2 and 3. We looked at our patients too and looked at the periictal MRI abnormalities, and we found that the same, that the acute primary and acute toxic, they had most often, significantly more often, periictal MRI changes as a marker of refractory status. Who will develop these periictal MRI abnormalities, which we see and recognize as indicator of brain damage? It's the duration, it's the refractoriness, it's the focal motor, which predominates over the generalized convulsive phase only. It's the one with impairment of consciousness from stupor to coma. And it is the EEG changes, lateralized periodic spike wave, and it's a comorbidity. So if you think about the previous work on the clustering, these are the clusters. These also determines the probability of periictal MRI abnormalities. So we have evidence that ongoing status epilepticus causes brain damage. So what we need to do is identify and treat the cause as early as possible, early treatment to prevent the long-term consequences and brain damage, and to stop this cascade of events from single seizures to status epilepticus as early as possible. So if you have already a refractory status epilepticus, there you have genetic and epigenetic changes, which makes it more difficult to control it. Early treatment is with benzodiazepines, phenobarbital. This is the best treatment, GABAergic anti-seizure medicine. All the later stages, well, we should use different mechanism of action. For instance, anti-glutamatergic treatments, such as ketamine, or we use also a mixture or a combination of drugs, levetiracetam, phenolacosamide, brivaracetam, and valproic acid. Early treatment with 2 anti-seizure medicines, to my opinion, would be a good option, but it has not been tested so far. Having said this, this is true for acute symptomatic and remote symptomatic cases, but we don't know whether the same mechanisms apply for epilepsies in childhood encephalopathies. They seem to be quite resistant against brain damage, but that's a very preliminary message which I convey here. And strategy 3 is the staged approach which we have according to these changes, GABAergic, non-GABAergic. Refractory status is around 30 to 60 minutes, what we have here. So these patients failed on benzos and they failed on an anti-seizure medicine, usually at a regular dose. What we find in population-based studies and in so-called real-life studies, that around 70% of patients is undertreated, underdosed. So the dose of the benzos is too low. But nevertheless, we are talking about the refractoriness, and we have to start anesthesia. And then it comes to super refractory, we have to choose whatever we have, and we don't have a lot of opportunities where we can say this works. So it is an evidence-free zone, unfortunately, and it is really depending on the comorbidity and on the strategy. So we have to do something about this. Number one, which anesthetic we use? Well, I come to the point later, but let me give you the scenario. You have defined refractory status, failed one benzo and failed one anti-seizure medicine. And then you say, well, let's try another anti-seizure medicine. That would be one approach. But you could also say, let's go directly to generalized anesthesia. Well, there is no clear answer to that, but at the moment, we say how much refractory status. Well, there are two types of status. One is responsive to anti-seizure medicines in 27%, and responsive to generalized anesthesia. That's 8%. So we may probably have to define better what we mean when we say refractory status epilepticus. There is varying degrees of refractoriness. Second important message is that with each step of treatment, and this comes from our large registry with over 1,000 patients, without coma induction before the third treatment step. So we have additional treatment steps, and we find responses in every treatment steps, which is here. So the consequence is that the response rate with each treatment step does not go down to zero like we could expect. No, there's in every step, there's a reasonable proportion of patients who respond. But there's a significant worsening after the second step, but not after the third, fourth, or fifth step. So it goes down, but then it stays horizontally. What anesthetics to use? We have midazolam, propofol, and thiopental. They have mainly GABAergic drugs. They act on the GABA A receptors synaptically, but also extrasynaptically. The GABAergic failure is related to the synaptically, but not to the extrasynaptically. So they have a different half-life, and if you look at midazolam, it has a short half-life, 30 minutes, but if you have a prolonged use, high dose, the half-life increases up to 50 hours. So it has a long, it does not take place in the same way as you see it with propofol, 2 hours half-life, and the pentobarbital and thiopental have a long half-life and a long washout period. They tend to accumulate, have a high risk of interaction. So which one to choose? Again, our global audit gave us some answers what is going on in the world in 50 countries. And what you see is that the first anesthetic agent was only 7% barbiturates. It was propofol mainly used in Europe, and in the other countries it was midazolam mainly used. And the percentage of seizure control does not drop after repeated cycles of anesthesia. As I said previously, with the anti-seizure medicine, each treatment step before coma induction had a certain response rate, and here also each anesthesia circle had a response rate. And what you see here is that even after 4 or 5 steps of circles, you still can have, in about 15%, a good outcome based on MRS. The number of dead people, of course, increased, but the message is that you should not give up. Outcome was not affected by the choice of these 3 drugs and the sequence. And good outcome can be expected, so never give up. Which anesthetic is the best? Thiopental or propofol? There was a randomized controlled trial. Andrea Rossetti from Switzerland designed it. Look at the low numbers. 24 patients were enrolled, but they aimed for 150. for adequate power. Barbiturate was associated with a significantly longer duration of mechanical ventilation, but the outcome was similar, and this study was notoriously underpowered. But when we look at what has been done, propofol and pentobarbital, most of the cases were in case series and very few randomized controlled trials. So this is from Simon Chauvin's review. Risk or rescue anesthetic drugs. Should we ever go to anesthesia if the patient is still breathing? Well, there was a provocative article by Raul Sutter. He said that there's a higher number of deaf people, and it's about 3 times increased, and there are more infections during status epilepticus, so the ICU stay is longer. Well, this was after additional adjustment for refractory status epilepticus, and it was still true, a correlation between that. So there might be something in the riskiness of anesthetic drugs, and we should search for different types of anesthesia. For instance, ketamine, which is a NMDA receptor blocker, blocks the ionotropic NMDA glutamate receptor. It is a racemate. You can have S-ketamine alone. The active metabolite is norketamine. It has a short half-life. It's very well tolerated, has no cardiorespiratory depression, and it has some disadvantages, psychedelic effects, but this does not matter in status epilepticus. There are few series. This is our first experience with ketamine, and we found 64% response in 42 patients of super refractory. So the response rate was between 60 and 90%. And when you look at the different series and look at the bolus or dose which was given, there is a clear heterogeneity. Ketamine is also important because it suppresses cortical spreading, which is a spreading depolarization slowly marching over the cortex. And this spreading depolarization is associated with poor outcome. So if you say spreading depolarization, the frequency and the duration is associated for poor outcome, ketamine stops status and has a good impact on spreading depolarization. So there is a trial going on in the US, the KET trial, the SKET, and they see whether this really improves outcome. So I would say ketamine has to be brought further up. Magnesium is one of the oldest substances which we have, and it's used in status epilepticus in 1901. It's a drug of choice in eclampsia, and there are very few papers, and usually what we do is we give 2 to 6 grams per hour to obtain a serum level of 3.5 millimole per liter, but there is no clear evidence. And there is a potential risk of interaction with digitoxin, barbiturates, calcium channel blockers, and maybe also on neuromuscular transmission. Dexmedetomidine, the next substance, which is extremely interesting because it's not GABAergic. It does not act on the GABAergic receptors. It is a potent A2 adrenal receptor agonist. And we started to use, or we use it for weaning, and when you have a withdrawal reaction, this really helps you to cope that down. But there are experimental data where dexmedetomidine, Dexdor, is strongly active as an anti-seizure drug in various seizure models, but there is unfortunately no published report in humans. So the dose is unknown. The dose is the one which we use for treating withdrawal symptoms. Neurosteroids have been there for a while, and I can make it short. Neurosteroids, progesterone, allopregnanolone, they have been very promising and has been tried in clinical trials, but they failed. The reason why is in this area, in this advanced status area, it's very complicated to make proper trial. Also, ganaxolone, which is a 3B methyl analog, was ineffective in the trial. Does not mean that it doesn't work. It was a difficult trial design, and maybe the answer is in this design. Inhalational anesthetics, sevoflurane, isoflurane, desflurane, they all have sedating, muscle relaxing, and mildly analgesic effect. They're all volatile anesthetics. They have a low metabolism, well controllable, but they cause a vasodilatation, and they have a different, I would say, a different MAC value, which you see here, which is the concentration which you have to apply through the ventilatory machine. So they have a disadvantage. They are nephrotoxic. They cause airway irritation, bronchospasm, etc. So it's not without risks. And in a systematic review, they found 19 studies reporting a response rate of 90% in adults and children. So the other option is to give whatever you have at hand. Perampanel as an anti-glutamatergic drug. It acts on the AMPA receptors. So we used it very early in 2019, and we found out that you have to start with a high dose. Here we started at 24 milligrams median. Now we start at 32 milligrams orally in refractory status epilepticus. The next drug is, to my opinion, very interesting. It's an intravenous topiramate. This topiramate is very unsoluble, and you need some substances to keep it in solution. On the left side, you see captisol, cyclodextrin, which is toxic itself, and you have to have a cap so you don't bring enough topiramate into solution. And we have a system, or we did it, that you combine it with meglumine, which is a solvent, and there are quite good stability with this drug. Experience in status epilepticus, yes, with the oral medication, a solution. There are several reports which we put. There was around 60% of patients who were controlled with oral topiramate, and this was the first in human case, which we published about 2 years ago. It was a patient pregnant, and she stopped topiramate and she ran into status, so we gave her topiramate intravenously, and the response speaks for itself, very well tolerated. Immunotherapy, well, we have methylprednisolone, immunoglobulins, and plasma exchange. Why do we do that? Because some of the refractory status, as I said previously, they are due to paraneoplastic or autoimmune-mediated encephalitis. What has been used most often is steroids, plasma exchange, immunoglobulins, rituximab, cyclophosphamide, and now also tocilizumab. Having said that, I have to remind you that the plasma exchange, which is a fantastic method, not only washes out the immunoglobulins, which you see here, but it has also profound changes on the interleukin profile. So after plasma exchange, they are increased. CRP goes up and then goes down in follow-up 1. Procalcitonin goes up. So there are a lot of effects which we still don't understand fully in plasma exchange. So not only washing out the immunoglobulins, but also modulating the immune system. Anakinra, an interleukin 1 receptor antagonist, which was used for for refractory status epilepticus in children and in other adults. It was regarded as safe. These were children, a series, but anakinra can have severe infections and DRESS. So if you are not experienced with that, it can be dangerous, but after a certain time, so let's say 2 weeks to 1 year, status was controlled. So it is a long-term investment, I have to say. Tocilizumab, as I mentioned, it's an interleukin-6 receptor inhibitor. These are the first series from Korea, where they gave it in NORSE, and they all had a higher interleukin-6 level at the beginning, so they did a cytokine profile. The response was quite dramatic with tocilizumab, but again, it takes some time to control status epilepticus. In the meantime, there is a whole array of immunomodulators, adalimumab, natalizumab, canakinumab, which have been tried in single case series or small case series and have been published. And they act mainly against interleukin 1 or interleukin 6. What is important is autoimmune encephalitis in adults is very often overdiagnosed. This is from a series from Sarosh Irani from the Mayo Clinic, and the differential diagnosis of presumed autoimmune encephalitis, they were anaplastic astrocytoma, primary CNS lymphoma, HIV leukencephalopathy, neurodegenerative dementia, insidious onset of dementia, and autopsy-confirmed Jakob-Creutzfeldt disease. So we had one case where antibodies were positive in Jakob-Creutzfeldt, and then we learned the antibodies are not specific. So you can have a different underlying disease. You test the antibody and it's positive. That doesn't mean that you have an autoimmune encephalitis. If you think about the side effects of the treatment, it has to be a very clear and firm diagnosis. Coming last to the non-pharmacological treatment, different types of stimulation, VNS, DBS, RNS, TDCS, they all have been tried. Repetitive transcranial nerve stimulation, they all have an effect on the nervous system. But are they effective in status epilepticus? Well, maybe. Success rates with TDCS, 0. RTMS, 40%. With cortical stimulation, 80% and around 70% with VNS. Again, uncontrolled series, there is a publication bias, and we have to learn a lot about what to do, what is the best parameter, what is the best target, how fast can we start with the treatment. And if we give treatments such as high-dose anesthesia, volatile anesthetics, immunotreatments, you have to look on the burden of treatment. So think about it. You have an structural damage which harms the brain. You have the burden of status epilepticus on top of that. Then you have the burden of treatment which can harm you. And then you have against the success of treatment, which can be, of course, mild or moderate, etc. And you have to think that the gain of treatment can best reverse the burden of status epilepticus, not the underlying cause. And the burden of treatment can, depending on the aggressiveness, overshadow the gain of treatment, and the balance goes to the other side. And the smaller the functional reserve is, which is individually to be defined, the earlier the stage of decompensation is reached. So I conclude, classification is based on semiology, etiology, and EEG, which forms biological classes. Convulsive and non-convulsive cluster in distinct prognostically relevant types. Not all refractory are the same, and response can be expected even after many treatment failure attempts. We have to identify and treat the cause, otherwise we will not succeed. And intravenous anesthetics and ketamine are the main treatments in super-refractory status epilepticus. I would prefer a combination of ketamine and midazolam. And the super refractory is an evidence-free zone. We need to have a protocol-driven approach. And I think important is the impact of burden. Previously, I said never give up. Yes, but always think on the harm of treatment and the aggressiveness of treatment. And the last point I want to make, you never walk alone because there are international collaborations. One is the European Reference Network EpiCare, where we specifically deal with difficult cases in the European Union. But there is also a NORSE Foundation in the US helping you with NORSE cases once you get in contact with them. So what you want to know about the hospital and the network, please scan me or scan this one. And I thank you very much for your attention.
So thank you very much, sir, for the very informative talk. And I think all of us have benefited with us. We have some time for the maybe 5-10 minutes for the questions, or you want? Great. So because focus on the refractory status, we have different anesthetic agents. So and then there has been different preferences. So all of us would like to know what is your sequence of the preference which you use in your patient. And the second part of the same question is that suppose once the one drug fails, then whether you will use the same drug or you will change to the another drug in the cycling of that therapy.
Well, first of all, there is no evidence. So whatever you do is your own experience. And my personal preference for anesthetic drugs is the combination of high-dose midazolam plus ketamine infusion. The second is ketamine plus propofol infusion. Ketamine alone, my personal view is it does not lead to a success if you use it only. It is very helpful in combinations. Having said that, in any case, when it comes to the refractory stage, you have to balance the risks against the benefits of the treatment. So if you have an elderly multimorbid patient, it would be better not to intubate too early, but to do it later. And I recently looked at all the evidence which we have for early intubation. There is no clear answer. So early intubation is not the answer to all the problems. So you have the same success with repeated intravenous medication in some of the patients. At the moment, we don't know. So my decision tree is related to the comorbidity, and then decide, and age, comorbidity and age goes well together, and then decide whether you add another drug before you intubate and ventilate. And the second question which you posed is changing anesthetic drug with each cycle, and the answer is yes, that would be an option. So the changes can be, of course, between anesthetic drugs and inhalational, and then you go back to intravenous anesthetics. If you are high-dose barbiturates, this would probably be the last option because of the long-lasting effect, because of you don't get it out of the body anymore, and because of the negative inotropic, because of the infections, etc. So this would be the last any option. But to switch between midazolam and ketamine and propofol, this is what we do. And yeah, I cannot tell you whether this is better. This is based on theory.
We understand that there is a definite lack of definitive evidence, and some of these are based on our experiences and anecdotal reports. So just want to clarify one thing. So you told that midazolam and ketamine infusion, or sorry, combination. So at the first outset, you start with this combination or one drug and then the other?
No, with a combination. With a combination. In some patients where you think, well, a short dose propofol alone is also something what you can do, but what I think is important to have early combinations in these treatments.
So, and one aspect, if I can ask, we have not, this because these are the practical questions, and obviously there are no clear-cut answers from the literature. So, about the EEG monitoring of the status epilepticus, usually we try to achieve a burst suppression pattern, and then we maintain it for 48 hours, and then we try to taper it off. That is a usual standard practice we follow. So, your thought on that? And
Yeah.
what should be the level of burst suppression?
Number one, if you use the different anesthetic drugs, you have barbiturates, propofol, and midazolam, and ketamine. With barbiturates, you have this as a target, burst suppression. With propofol, probably it's not the right target because it needs high doses to get that, if at all. Midazolam, you don't get it, and with ketamine, you don't get burst suppression. So it depends on the drug which you apply, and with dexmedetomidine, you don't get it at all. But it depends on the type of drug. Whether propofol is already in the high burden of treatment, doing harm or not, I don't know. My feeling is that it is too high of a dose. And if we think differently, we can say with continuous EEG monitoring, the goal is seizure suppression and not silencing down all the activities with all the potential side effects.
So that's, I think, a very useful message which we have got. And then one other is that once you are cycling the anesthetic agents, at the same one drug fails and patient has a recurrence of seizure, then we have a tendency to continuing adding on these anti-seizure medicines. So what happens that after a week or 10 days, patient may be on 7 or 8 anti-seizure medicine apart from the anesthetic agents. So would you do that, or probably after 2 or 3 medicine you will stop and then try the anesthetic agents? So what will be your preference on that?
Well, I think it's important to stop because what we what we know is that one anti-seizure medicine doesn't work. You give the second, doesn't work. You give the third, doesn't work. So why not simplify it and take it down to 1 or 2 drugs as a baseline medication? So I think this is then a balance. Once you control it with anesthetics, you have to go out with the oral medication. Also thinking about an ICU patient with a typical gastric paresis, with a poor absorption, with a high risk of interactions. So I would simplify the oral medication as much as possible. And when we have these international case conferences, this is one of the first recommendations which we give. Simplify the oral nasogastric application to a maximum so that you can at least think you have an overview of what you're doing. If you have 5 drugs up and down, as no one can really say that he or she knows what is going on.
Thank you very much, sir. We have Gagandeep sir also with us and Dr. Mamta, chairperson of the epilepsy subsection.
Hello,
If I
Gagan.
can invite for their comments or questions, sir.
So I would just want to ask, that was a wonderful talk, and I think all of us have really benefited. You've done so much work on this. So, about the intubation bit, I mean, I don't know. We are never able to avoid intubating these patients. We more or less almost always end up intubating them. So, I mean, I don't know how you said that, you would try and defer that.
So one of the rule of thumb was some years ago, as early as possible intubation. So which means that if you have a patient in ongoing status and he failed 2 anti-seizure medicines, don't try a third one. But this is what we do now. We try a third one because we have the response very early. So levetiracetam, it takes 5 minutes. Valproic acid, 5 to 10 minutes. Lacosamide, maybe 10 minutes. So you don't lose a lot of time and you see a response. So the change in paradigm was, for us at least, that we We use the continuous EEG monitoring, or you can even do it in the emergency setting with the EEG cap on, and you see a response. This is then where you stay. So previously, there was no other measure, and we did not use acute EEG in the acute setting some years ago. So it was a blind flight. You had no other option because you don't know whether the patient is sedated or whether the patient is in ongoing status. Now you know clearly, well, it's ongoing status. Patient is sedated, but it's still ongoing status. So then you can try another one. So this changed a little bit, and this is why early intubation is no longer the leading paradigm.
So probably, our patients may be a little different from the ones that you see, because I
Yeah,
think we probably end up seeing them pretty late,
yeah.
not very early. So probably they've already failed multiple drugs at other places before they turn up at our hospitals in tertiary care over here. The other question I was wondering is, looking at that slide, I was very impressed with that 98 point some percent of patients having, like de novo status and refractory or super refractory, and many of them may have immune mediated etiologies. So I was wondering if, how quick should one be in offering or trying out immunotherapies?
Um, yes, that is a very good question. And I tell you, there are two concepts. One is once status is refractory, there must be an immune cause.
Mm.
It's not always the case. There are only few are really immune causes. And if you look at those which are labeled at NORSE, only half of them maximum had in adults had immune cause. That's hypothesis one, and that would be an argument for immune treatment. Hypothesis two is that ongoing seizure activity causes an inflammatory response, a glial response. This is true, but it can be a reaction of seizures, and it can be an adaptive process. So there is no evidence that tuning down the immune system per se stop seizures. In animal experiments, there is evidence. In humans, the drugs which were developed by Anna Maria Vezzani failed to do that. And so the evidence is very weak. And I'm no longer a friend of treating blindly with immune modulation. Methylprednisolone may be something different because it's a stress hormone which mobilizes a lot of things. It's not only immunomodulating, but it's also a metabolic, a doping for the body. So this is probably when we say it's immune modulatory, it's only part of the equation.
Okay, thank you. So have a great evening with the orchestra. And because you are short on time, I'll pass it over to Gagandeep. He might have some questions.
Um, Eugen, I absolutely enjoyed your talk, as always. Thank you so
Thank
much.
you.
And I was about to ask this question, which Mamta actually asked before me, is when do we introduce immune therapy, very early or late? And I think you've very elegantly answered that. So really, I think it's been a wonderful talk. And as always, Eugen is the master of status epilepticus. So it's so much a pleasure always listening to you. Thank you so
Thank
much.
you.
So if
Thank
there's
you so much.
just scope for just one question, so
Yes.
this is not in the context of refractory or super refractory status, but this is status in general. So, for example, in a country like ours, patients are not always within reach of, even secondary care, leave alone tertiary.
Yes.
So, when status is happening in a primary care setting with limited resources, what would you think is the role for rescue medication?
Yeah, I think this is extremely important. So and I didn't go into that too much because I think the offensive treatment strategy is not wait until that and then see whether we can stop as early as possible. So we have very effective drugs, which are benzodiazepines, and they are not expensive. They can be used also by caregivers. Depending on the legal situation, at least in our country, parents and caregivers for epilepsy patients can use it. If you think on de novo status epilepticus, primary caregivers should be allowed to give early benzodiazepine. And what we know with with nasal and with
Yeah.
buccal routes and with intramuscular routes, the success rate is the highest when you give it earlier.
As early as possible. Yeah.
As early as possible. And we need to do that. And that's based on education. That's based on the legal framework. That's based on the security. So if this can be managed, I think the number of refractory status will decrease.
Yeah. Mm.
This.
Yeah. Yeah, that really helps. That really helps. So, Gagandeep, that's something for us to keep in mind.
Thank you very much, sir, for the very magnificent and very educative talk. I think all of us have benefited with us, and I am sure that now we know that Salzburg is not only known by the Mozart, but by the Dr. Klinka's name also, so Salzburg's criteria. So on behalf of Indian Academy of Neurology and all the neurology fraternity from all across India, once again, thank you for sparing this time. And we wish you a very good evening and have a happy time at the opera. Thank you very much, sir.
Thank you. Thank you very much. Thank you. It was a pleasure to see you, and I hope to see you soon in Lisbon or anywhere else in the world.
Some of us will be there, sir. Thank you.
Bye-bye.